The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of The Genuine Article. And on this occasion, I'm talking to Dr. Lars Kober. And Lars is professor of cardiology at University Hospital in Copenhagen. And Lars is one of the authors of a study in JACC that has been directed towards studying the effect of clopidogrel in post-myocardial infarction patients who have not undergone PCI, and especially with an eye on heart failure. Lars, tell us about your study. What prompted you to do it?
Thank you. It's a pleasure to be here. First of all, this is a serious study. We started by studying in a nation how many patients are actually treated with clopidogrel, and then we found out that patients are actually undertreated. There is a steadying rise in the treatment of clopidogrel, but we found out that especially vulnerable patients like heart failure patients were not treated. And I think this comes from previous studies where they showed that, well, these patients have not been studied in detail. So we looked at who received it, and if they received it, how is the outcome of patients with heart failure.
Okay, so this was really a registry study. Denmark is very well suited to perform these registry studies, isn't it? You can keep track of your patients quite well.
Exactly. We're a small country, 5.5 million, but we know where everyone lives and how it goes. So we can combine registers, and we have no patients lost to follow up.
And so what you did is you took a group of post-MI patients who had not undergone percutaneous intervention, and you compared the patients who were treated subsequently with clopidogrel with the patients who were not, and then looked separately at the patients with heart failure and those without, as I understand the study. And what did you find?
Exactly. And what we found was that patients who had heart failure seemed to benefit when they were treated with clopidogrel. There was a 12 to 14% risk reduction in all-cause mortality if they had heart failure. In the non-heart failure group, there was a smaller beneficial effect of 2 to 4%, but this was not significant as in the heart failure patients. So it looks like if people are afraid of treating heart failure patients with clopidogrel on top of aspirin, there's no reason to be that. I know it's a registered study, but these associations were quite striking.
So I think based on CURE and COMMIT trials that there's a consensus that clopidogrel probably is indicated in patients who've had a myocardial infarction. How does your study add to that?
Yeah, you see, the CURE study did not actually include very many patients with heart failure, and it found a risk reduction in a combined endpoint of death, AMI, and stroke, while in the COMMIT trial there was a reduction in all-cause mortality within 28 days, and that actually included 25% of patients with heart failure. So it's really telling us that this could be the explanation why it was that good in the COMMIT trial. And secondly, when you have clinical trials, you have problems with that patients are very selected, and this we now take out to a whole nation where there's no restriction with age, gender, anything you actually could say, because this is a prescription study. We just look at who is going to take the prescription afterwards.
Now, do you think that there's something unique about the pathophysiology of heart failure, or was heart failure just a marker of a sicker patient who needed clopidogrel more?
Yeah, I think that's a very interesting question, because it could be both. Heart failure is a atherothrombotic disease, and they have a high likelihood of having thrombotic events. So there could be a special beneficial effect in heart failure patients. I think we need a study to see that. But secondly, yes, it is a real marker of high risk.
Well, there's no question that your study has really reinforced the need to treat post-MI patients with clopidogrel, especially if they have heart failure, whether or not they undergo PCI. Thanks very much for being with us. And for the Genuine Article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.